For today's session, let me welcome Ruchik Mishra from University of Louisville. And he'll be talking about the personalized and adaptive robotic intervention for children with autism spectrum disorder. So about Ruchik, Ruchik is a PhD candidate at Louisville Automation and Robotics Research Institute in the Department of Electrical and Computer Engineering at University of Louisville. His current research spans in the areas of affective computing, deep learning, and robotics, and their application in healthcare. It involves modeling of during the therapy session of children with autism spectrum disorder. And the prime focus of his research is to leverage deep learning algorithms to create an emotional feedback between a robot and a child in the context of autism therapy to facilitate personalized robotic interventions. So now let me welcome Ruchik to share his screen and present the talk. Thank you.
Well, hello everyone, and thanks for the introduction. I'm happy to be here and talking robotics. I mean, personally, I feel that it's like a great platform to discuss, as you mentioned, ideas with the research community, and it especially gives PhD students such as myself who are like early in their careers to get some of that additional feedback. And because there's still ongoing research going on, and there's still some time to incorporate those additional feedbacks and ideas into the project. This platform really gives, provides that additional sort of a platform to discuss these ideas. And so, I mean, having said that, I would definitely encourage anyone who is present in this session to ask as many questions as you can at the end of the session, or, you can also interrupt me while I'm speaking if you feel that I said something, really incorrect. So, as mentioned that, okay, today my talk will comprise of, the topic of the talk would be personalized and adaptive robotic intervention for children with autism spectrum disorder. And let's sort of jump to the table of contents. Okay. So I have divided this presentation into three broad categories. I'll start with a brief about my research area and the spectrum of applications we have. The second part will be about autism spectrum disorder, which would lay the foundation of what application area I'm working on. And it sort of would lay the motivation like behind this particular application area and why we are looking at a closed loop HRI. And the last part would comprise of the robotic intervention side of the story. And today's talk would be more of an overview of my ongoing research project. This the domain it would encompass would be, as mentioned, robotics, healthcare, deep learning, and affective computing. And in the intersection of these areas lies my topic of PhD, which is to develop closed loop HRI solutions for children with ASD. Now, human-robot interaction as such, as of today, isn't confined to the spaces of just academia. It's already made its way out in the real-world settings with some real-world challenges. And in the current times, we see robots being used in, say, for example, household environments, or assistive technologies in warehouses, collaborative or joint task environments, in restaurants, or even for entertainment purposes, such as this scenario over here, where the robot is being used as an adversarial opponent in a physically interactive robo game. If we specifically see the domain of healthcare, the advantages of robots have been immense. Some examples are robots being used as an assistive technology for people with visual impairments to help them sort of navigate in their operating environment. Then there are robots which are being used as telepresence in hospitals to provide medical expertise, essentially for patients where in-person care may or may not be available. The third example here describes a surgical, demonstrates a surgical robot, which is mostly teleoperated by a surgeon. And then the last shows an example of a robot being used in a COVID situation in hospitals where, to help frontline workers stay safe. In all of these HRI scenarios, although there is an element of a human interacting with a robot, it's either supervised, teleoperated, or has less to no human feedback as inputs to adapt to the behavior or the emotion of a human. Now, the HRI involved in a robotic intervention of children with ASD so far involves mostly three intersecting areas where it's either collaborative, assistive, or teleoperated. But even before I talk about the robotic element of the intervention or robot-specific views of the intervention, let's see what autism spectrum disorder is and why we're using robots in the first place for such an intervention. So let me begin with showing you a short video, and I'll present three different scenarios and characteristics between a neurotypical child and a child with ASD. So as you see on the left-hand side of the frame, so on the left-hand side is an example of a neurotypical child who's involved in a one-to-one interaction with a person. Now, during this conversation, the child makes good eye contact with the person, and it's like sitting still and having a good rapport with the communicator. Whereas the child on the right-hand side isn't able to do that. He refrains from making any one-to-one, like good eye contact while being involved in a one-to-one communication. Now, in the second case, the child on the left displays a good posture during a one-to-one communication, whereas the child on the right is involved in sort of a repetitive activity that has nothing to do with the ongoing conversation. In the third scenario here, as you see, this is where the amount of sensory input is large, such as in this example, it's a grocery store. So the neurotypical child on the left seems to be calm and composed, whereas the child on the right shows signs of meltdowns. Now, these are some of the examples of characteristics shown by children with ASD, which align with the Diagnostic and Statistical Manual of Mental Health Disorders, the 5th edition, also called DSM-5. And according to DSM-5, it states that children with ASD show problems with social interaction and communication and repetitive or restrictive behaviors. Now, currently, the ASD population, as per some prior studies published in 2014, was about 1.5%. It comprises of 1.5% of the world population, in which 1 out of every 54 children in the US alone were within the spectrum. And a recent 2020 report by the Centers for Disease Control and Prevention stated that this percentage has gone up by 104% in the last decade. Hence, interventions that are sustainable and can fetch real positive results become imperative. Now, ASD is a neurodevelopmental disorder for which no cure exists as such, but there are treatments available, there are interventions. And one of the articles published like last year in the Journal of Autism and Developmental Disorders states, and I quote, "Where there is no cure, there are countless treatments." And that's been the case so far. And however, not all of these interventions are proven to be scientifically sound. Some examples that I have mentioned here are like the non-evidence-based intervention like chelation therapy from 2015, or interventions lacking empirical support like social thinking from 2018, pseudoscientific interventions like Sunrise, or even anti-scientific interventions like facilitated communication from 2014. Now, in order to solve this issue of following practices that lack enough scientific evidence, the National Clearinghouse on Autism Evidence and Practice, NCAPE, so this review team came up with the third iteration of the evidence-based practices for children, youth, and young adults with autism. And the NCAPE report provides a valuable contribution to the field of ASD as far as intervention goes, by sort of trying to help consumers better identify which interventions are evidence-based, which interventions have scientific evidence behind them. And like reports like this can sort of result, can help individuals diagnosed with ASD to contact or to communicate with only those centers where the evidence-based practices are being, adopted, so as to save them copious amounts of money. On that note, as far as the interventions specific to robotics are concerned, in the context of ASD or children with ASD, in the past decade alone, there have been numerous studies made in the literature, some even in like specific to Journal of Developmental Disorder or Research in Autism Spectrum Disorders, that have highlighted the positive effects of using robots as the center of the intervention. And these positive effects aren't specific to like a certain direction of intervention or like a certain type of intervention, but they cover a wider scope. In addition, they're also not limited by a certain kind of robot, but have been used with a variety of robots that are available in the market. And based on these studies, along with lots of other ones too, the NCAPE included the technology-aided instruction and intervention as a part of the evidence-based practices document of 2020. Now, a point worth noting is that in TAII, which is the technology-aided instruction, the technology is the central focus of the intervention, and not just the general use of technology like visual aids, monitors, alarms, phones, video modeling, etc. And the use of robots has also been explicitly highlighted, as you see in this document here. In addition to just laying down points on what technologies can be used, it also specifies in what age ranges can these technologies be used, and what should be the intended outcomes of this kind of technology, or whatever kind of technology we're trying to use, having that have already proven to form some scientific evidence of positive effects when being used in a like a therapy scenario. As far as the robotic intervention of ASD goes, this is sort of a review kind of paper that we had last year. And the general sort of pipeline starts first with the diagnosis, which includes ADOS or any other diagnostic tool to screen people for ASD. And then based on the requirements, the individual is sort of referred to the kind of therapy they need. Now, for robotic intervention, three broad categories exist. The first is remotely controlled or Wizard of Oz approach, where the robot is completely teleoperated and all the commands of speech, etc., is done by the therapist through the robot. The second channel is semi-autonomous mode, where the robot acts as an assistive agent or even as an autonomous agent, but with the therapist has the power to override the decisions or actions made by the robot. And the final category is the fully autonomous mode. The next stage in the pipeline is the generation of the content based on an engagement feedback loop, about which I'll talk a little later. And so this is where the content gets generated specific to a certain kind of therapy that the child may be involved in. And it's completely based on personal needs, based on the individual's needs and the recommendation of the therapist. And finally, at the end of this pipeline is the evaluation step, which is to find out if the outcomes of the intervention were achieved or not. So far, I have talked about the idea that robotic intervention has shown positive outcomes based on the literature in case of children with ASD, and that too based on evidence-based practices which were laid down by NCAPE document. But there are still limitations to using robots in a clinical setting. Multiple instances, robots have been termed as entertainment agents rather than serious elements that could be used to deliver high-end care. And this can be because of a number of factors. I mean, one of these factors have been highlighted in two recent studies in the Journal of Developmental Disorders that have that have discussed in detail the gaps that exist in the current literature of robotic interventions, some of which are the lack of longitudinal data. Second, there have been less studies to find out the merit of robot-led interventions when compared directly to a human-led intervention. This is to say that if robots are considered in a study, they seem to fetch positive results towards an intended outcome. But when compared against humans, they do not always have comparable levels of outcomes. Now, another point that contributes to this gap is the lack of follow-up evaluations. This essentially makes it difficult to find out for sure if the intervention was any helpful in the long run. Some other points that have been mentioned in these studies include the use of different varieties of robots, difficulty in generalization, and even technical difficulties like the robot shutting down or not being able to record or receive commands from the person it's trying to set up the communication with. And further, in the second study, some of these challenges were addressed specific to the Casper robot, and the challenges were described in a more robot-specific manner than robots in general. And so, since in all our studies, we are using the now robot, we follow a more robot-specific approach in our work too, and anticipating our usage of the now robot to be more verbal than motion-based, we conducted a social impression study using the now robot, where we recruited 30 neurotypical adults with a mean age of 21.4 years. And in these sessions, the human and the robot were involved in a one-to-one communication where the participant asks questions to the robot of a predefined script, and the robot answers to these questions and then repeats these questions back to the participant to answer. And these questions are like general questions like, hi, what's your name? Or how are you doing? Or what do you like doing in general? And so this is like a back and forth communication between the robot and the human. Now, during these sessions, we used 4 different conditions of interaction, where condition A is using the default now voice with smooth motions. Condition B is the Amazon Polly Justin voice with smooth motions. And conditions C and D are the jerky motion variants with the same voice types used in A and B. And these 4 modalities of the robot are were judged on 5 perceived features. They were perceived safety, anthropomorphism, animacy, likability, and perceived intelligence. And based on our statistical analysis, we arrived at some conclusions that would help us select among these 4 different modalities for our future studies. For perceived safety, we found that Amazon Polly Justin voice with smooth motions performed the best, followed by the default now voice with smooth motion types. As far as anthropomorphism, the nature of the robot goes, the default now voice with smooth motions performed better than the Amazon Polly Justin voice. And the same result continued for likability of the robot. However, the default now voice with jerky motions was liked second, like it came second in place, followed by the condition A, which is default now voice with smooth motions. And similarly, these comparisons were made for the rest of the perceived features too. In addition to using different modalities of the robot, we also took into account prior experience of the participants with robots in general. We asked each participant to rate their experience on a scale of 0 to 3, where 0 signifies no experience with the robots, 1 signifies some fundamental awareness, 2 signifies limited experience with robots, and 3 signifies an intermediate stage where the participant has completed some practical applications with robots. And the significance of experience with robots was significant only for 2 perceived features under some conditions. For example, experience with robots mattered or was significant with anthropomorphism under condition A. Now, likability was significant under condition A, C, and D. And so these were sort of some results and conclusions that we came up at the end of our social impression study. Now, let's take a moment away from these social impressions for a couple of slides and then talk about the motivation behind closed-loop HRI for children with ASD. Now, as I described in the general pipeline earlier of using robots and interventions, right now I would like to give the motivation behind using a closed-loop HRI as far as the robotic intervention ASD children with ASD go. So let's start with this video. As you see, the person during this intervention is no longer involved in the activities of the therapy, but is going through a meltdown stage. Now, this can happen due to a number of reasons. One of them is being being overwhelmed from the contents itself, if the activities are too difficult. And such meltdowns can escalate into aggression and can motivate the person to cause harm to self or to others. And the aim is to really avoid these kinds of challenging behaviors. So that we can keep the person away. So that we can keep the person on track and keep them continuously benefiting from the intervention and not being engaged, as in Apart from just the challenging behaviors or meltdowns and aggression, not being engaged during a session can also lead to a failure to attain the goals of the intervention. And this is where our idea of the closed loop HRI comes into the picture, where when we talk about robotic intervention, it starts with the child with ASD, where we collect physiological responses using a wearable sensor called the Empatica E4. It's a portable wristband. These physiological signals give us an idea of the affective states of the person. Uh, and based on these affective states, and like we make decisions on the kind of content that the robot should be generating during the therapy session. Now, to highlight more on the physiological signals, let's see what the Empatica E4 collects. Well, it collects the blood volume pulse, also called BVP, the electrodermal activity, EDA, skin temperature, and accelerations in X, Y, and Z directions. And here are some plots to show the shape of these signals, essentially to visualize how these signals essentially look like. The reason we're using physiology is because physiological signals have been shown to be good indicators of the affective states of a person. Now, this modality of perception becomes essential given the fact that we are dealing with human subjects data, and that to children with autism. It's been shown in previous studies that facial expressions as such, when it's being used as a modality for children with ASD, may not be a good indicator of the affective states or emotions of a person. Hence, we currently rely on the collection of the physiological data to make predictions of the affective states or even engagement levels of the person involved in the intervention. Now, here's an example of how physiological measures can be used. Let's consider again the social impression study that I was discussing a couple of slides earlier. Remember, I mentioned that 4 different modalities of the robot were used using different voice types with smooth versus jerky motions. Now, even those situations had different physiological responses in individuals. Each of the individuals in the study wore the Empatica E4 wristband, and their physiological responses were recorded under all of these 4 conditions or different voice types and different smooth versus jerky motions. And we used the blood volume pulse specifically in this case, since the BVP data was collected at 64 hertz as compared to just 4 hertz of electrodermal activity. And we used a sort of a convolutional neural network to examine if it was able to differentiate between physiologies under these 4 conditions, which it did with a good enough 81% accuracy. So far we have looked at the social impression study and how different modalities have an impact on the HR, on the physiological responses. Now, in addition, we looked at our motivation behind using closed loop HRI solutions, which is to predict challenging behaviors or meltdowns, or even predict levels of engagement while in therapy. And extend this idea a little bit further. What if we could forecast a challenging behavior or forecast a disengagement for future time steps? And this way we could adapt to the therapy sessions appropriately. In this study described here, we have an interactive session between 2 children with ASD, where the robot acts as a prompter. The children are involved in candid conversations about their lives in general. And in case there's a silence for more than 30 seconds, the robot tries to facilitate the conversation by encouraging them to ask questions to each other. And just as a repetition of what I had mentioned earlier, we are using the Now robot in all of our analysis. This is because there are no facial expressions as such on the Now robot, and that's what we are looking for while considering children with ASD, since less to no facial expressions would provide fewer channels to process during communicating or even prompting. So let's go over a few details of the forecasting study on how physiology helps in this aspect. This is essentially the idea derived from the deep learning literature, where the time series forecasts have been there for a while now. So we use the Empatica E4 to collect the physiological signals in this case to especially the BVP, since as I mentioned, it's got a higher frequency of attaining this data. When used as a combination used as a combination of LSTMs and CNN layers to extract temporals and spatial features from the data to forecast the signal for future time steps. So how does this engagement be a part of this network? So since we have a team of some medical practitioners, doctors, and child health experts, we obtain labels for our supervised learning algorithms. So we obtain labels of engagement or being attentive and disengagement or being inattentive through their labeling. Now, this labeling is done for each 20 seconds, for each 20-second segments. And once the signal has been forecasted for a few steps into the future, the classification layer can then separate this data into the engagement versus the disengagement, or attentive versus inattentive labels. Now, this brings us to the last segment of this talk. So far, we saw the first two segments of the closed loop HRI, where we collected physiological signals and made predictions of the engagement levels for future time steps. Now, the third point, the third and the last point is the generation of appropriate content during intervention. So currently, we are looking at theory of mind and perspective taking type of interventions. So just sort of to give a broader idea of what theory of mind and perspective taking are. Theory of mind is the ability to reason about the mental state of other agents, and perspective taking encompasses empathetic reasoning. So we are kind of headed towards this activity in our upcoming studies, and this sort of our future work and where we're headed towards. So we want to generate appropriate content in alignment with the theory of mind or perspective taking paradigms, so as to make these questions suited towards children with ASD. Currently we're considering 8 to 12 years as the age group. So we want to make appropriate content for that age group, taking into consideration the engagement levels of the child or the affective feedback of the child. Now, just as an example of what kind of as an example of a first order belief from Sally Ann type questions or Sally Ann type tests, let me just go over a few statements as to what theory of mind content would look like. So, for example, Sally puts an object into a container, and Annie moves the object without Sally observing this action. And now the child is asked questions related to first order beliefs like, where will Sally look for the marble? And reality type questions like, where is the marble really? And memory type questions like, where the marble was in the beginning. So this is kind of a future activity of the future work that we're looking towards. And coming to the conclusions. So far, based on the literature review and based on the papers that I have referenced so far in this talk, in conclusion, I would like to make 3 broad summary points. First, forecasting engagement or affect in children with ASD can help prevent meltdowns or challenging behaviors. Second, affect-driven feedback serves as an important indicator for characterizing engagement or affective states of children with ASD, since other modalities like facial expressions may not be very conclusive. Third, the above 2 points can be used towards adaptive intervention to make interventions more personalized for individuals with ASD. In the end, I would like to acknowledge my supervisor, Dr. Carla Welch. She's associated with the Department of Electrical and Computer Engineering at the University of Louisville. And I would also like to acknowledge National Science Foundation's grant, Smart and Connected Health, and NSF's EPSCoR grant. And with this, I would like to conclude my talk. Thank you for providing me this platform to express my research ideas and future work. And yeah, I am ready to take any questions if you have some, and we'll be looking forward to the discussions. Thank you.
Thank you, Ruchik. Are there any questions?
Okay. So you mentioned about the using physiological features for the estimation as well as the forecast of engagement. Have you considered like using like blending other sources of information such as um, nonverbal behaviors alongside uh, even to maybe to verify if both these data aligns in terms of the affective information?
Yeah, so just to rephrase, I mean, the question you're asking about, like, are we trying to use a multimodal data set for essentially trying to find out if a forecast plus a classification kind of a problem would work for children with ASD? So
Yes.
yeah, I mean, we are considering using a multimodal data set. Also, so currently we're using a univariate time series because it's just BVP or blood volume pulse data, right? So not only are we trying to extend that to a multivariate time series, like incorporating electrodermal activity and also skin temperature to see how conclusive like these further physiological signals are, but we're also trying to incorporate body pose. So like I have referenced a couple of studies in my slides, one of which was a 2018 study from Science Robotics. So in that paper, they have characterized sort of, how can we talk about engagement in children with ASD. So physiological signals and body pose have sort of occupied the top two spots of modalities that can be a reliable source of information. Not so much as facial expressions, also, based on the testimonies of different therapists that we have on our team. Even though their ideas also align with the same fact that, okay, not so much with the facial expression, but yeah, again, probably body pose can be one other modality that if someone has to look immediately beyond physiological signals, then yeah, body pose would be the immediate next step that we would like to incorporate in a study.
Yes, absolutely. Thank you.
Thank you.
There is one question in the chat from Akhil John. I'll read it out. Do you know if there are any commercial applications that are being developed for forecasting these behaviors?
So as far as forecasting goes, so far I have come across one, sort of one paper in the literature where they've actually talked about forecasting, but not so much in the commercial domain. I mean, I've seen classification problems being addressed, like how we can classify different, 6 primary emotions, or even say differentiate between a positive affect or a negative affect. But as far as forecasting goes, I haven't, seen like forecasting time series. That's again there in the deep learning literature, and people have been working for a while now. But forecasting engagement based on the physiology of the person, not so much yet. I mean, commercially, no, even in like papers, just one, but that particular work doesn't take into account the raw signals, but it sort of extracts. It's more like a machine learning approach for fixed time windows, and it's not so much robust in expanding those capabilities, for a longer sequence or for a much longer therapy or intervention session as such.
Okay, thank you.
I hope that answered your question. So you can let me know in the chat.
Hello. So I have one question. Thanks for the nice talk. It's Javeria here. So there's one thing on which I would like some clarification. Maybe you did mention that, I missed it, but I was wondering what is, with all the studies or the kind of interventions that you mentioned, what is the goal, the long-term goal of these robotic interventions? For example, is it to develop certain skills, particular skills in the autistic children? And are these therapy sessions independently happening without therapists getting involved, or is it supposed to be complementary to the role of a therapist? So what is the role of a therapist in this entire loop?
Okay. So to answer, from the beginning of what you asked, So it's a goal-oriented sort of an intervention where we are trying to develop certain social skills. So currently, as I mentioned in this previous slide, that we're trying to see, generate theory of mind kind of content. So it's like asking the child with ASD, okay, let's say we present a scenario, we present a story that this is the situation where one has to be empathetic to say, for example, I tell a story, right? That a certain person gets involved in a certain activity, which gives rise to a certain kind of an effect in the person. So then, based on the story, we would like to ask the child, okay, what do you think the protagonist of the story is feeling at this current moment? So to sort of, develop that kind of an empathetic feeling in the child is what we are aiming towards at this current stage. And as far as the second part of the question, which you asked, that, okay, what's the role of the therapist in all of these scenarios? So currently, like the places where, say, the robotic intervention has basically come up is where, there's need of an assistive agent, not like a completely autonomous at this current moment, but more like an assistive agent where, so there are a couple of, like a number of activities that can happen during a certain session. It can be like keeping track of the data, keeping track of the questions next to ask, and keeping track of if, like, how the child might be feeling. So all these are like different channels that one, like a human, has to process. So bringing a robot in that scenario can help with maybe data collection, or maybe generating an adaptive and coherent and context aware content in that time frame, so that the say, for example, the attention of the therapist isn't like divided or compromised based on any of the, like multitude of activities that one has to go through during one therapy session. So the role of the robot currently would be more assistive, or act as a more assistive technology, with the therapist being present in the same session and trying to, uh, sort of label the data for us, judge the data for us, and if there's a meltdown scenario, then would really try to calm the person down, or whatever activities they have for such a scenario as meltdowns, aggressive behaviors, or any of those challenging behaviors. So I would say it's more of an assistive technology at this current moment, at least for us. Yeah.
Okay, thank you. That answers my questions.
Thank you.
Thank you for your talk, Ruchik. That was an interesting talk.
Thank
I'm
you.
Ujjal, and I'm new to the area of social robotics. So my question may come off as a bit of an amateur, but I wanted to ask about this slide itself, that you've shown the Now robot involved in the closed loop HRI.
Mhm.
And does the Now robot have only a conversation, or does it include the smooth motions that you were talking about in the previous slides?
So the Now robot has 25 degrees of freedom almost, right? So it's capable of making some complex maneuvers, complex motions, a whole bunch of activities. And in the past, we have done a couple of activities that has to do with hand motions, or directing, or like giving fist bumps, and all sorts of activities. But currently, as I had mentioned in one of the previous slides, that our goal currently is more towards a verbal communication as far as the Now robot is concerned, while also not being completely still and speaking, because that's not very anthropomorphic. So we would like to make certain sort of hand gestures, not like defined hand gestures, but smooth, not so jittery, and just to make it look more human like. So that's the only motion that we're currently looking at. However, there have been activities in the past where people have been, like some sorts of activities with children with ASD can be like pick and place tasks, or handing over certain objects to the children. So those kind of motions would be more like heavy on the motion primitive side and not on the verbal side, but ours is more on the verbal side at this current moment.
Okay, I understand. That's really interesting, combining the possibilities of taking Now as a, like the motions of Now as a modal feature that you're talking about. So maybe that could be one of the future directions. The direction that you're going in is really interesting. Thank you for your talk.
Thank you so much.
I would like to go to the conclusion of the session. So once again, thank you, Ruchik, for the presentation. I think your goal towards working on empathetic things such as like perspective taking and empathetic reasoning seems very much interesting. And I also think that having a more emotionally aware robot assistant alongside can make a big difference in this kind of interactions. So good luck for all your future experiments and research. And thanks for joining Talking Robotics and presenting your research.
Thank you so much for
Thanks a
having me on
lot.
this platform. Thank you.
Sure.